our final panel. Thank you, everyone, for joining us. Thank you for taking a short break so that we could get into our panel. I'm gonna introduce our panel members now, and we have our first panelist is Sheriff Easter from Sedgwick County. Sheriff Easter is a native of Kansas, went to Friends University, began his law enforcement career with the Wichita Police Department in 1989 until he retired from the Wichita Police Department in 2012. Sheriff Easter was elected as sheriff in Sedgwick County in 2012, supervises over 550 employees, and in 2019, Sheriff Easter was the Kansas Sheriff's Association Sheriff of the Year, involved in many mental health related initiatives in Sedgwick County. And I will also tell you this about Sheriff Easter. 18 months ago when we started to plan this summit, Sheriff Easter was one of the first people that I reached out to. I've never met him before, scheduled this Zoom meeting. I'm actually kind of nervous going into this Zoom meeting, and I have my argument in place that I'm going to try to persuade Sheriff Easter to come be a part of this summit. And it was good. It was a really good argument. I was ready. And about 60 seconds into it, he said, "Yeah, I'll come." And I was like, "Well, this other stuff's good." No, it's he's been willing from the beginning to be here, and it's a pleasure to have Sheriff Easter here. And let's please welcome Sheriff Easter. Our next panelist is Lane Mangles. Mr. Mangles works with the KLETC, the Kansas Law Enforcement Training Center in Yoder, and has since 2019. Prior to that, not only does he now train law enforcement, but prior to that, Mr. Mangles worked for the Salina Police Department for 18 years and has had an extensive history with CIT Training and CIT organizations, formally serving on the CIT Association board and educating officers. And when it comes to his career, he was a field training officer, narcotics detective, patrol canine handler, criminal detective, and he now teaches law enforcement here in Kansas on a variety of topics, teaches statewide, and helps our law enforcement in our state be ready to take the field as it relates to mental health issues and CIT training. Please welcome Lane Mangles. We also have Dr. Balfour. Well, they already heard your introduction, so I thought if I said it again, it'd be kind of awkward. So our last panelist is Brynn Haverkamp and joins us from Pawnee Mental Health. She is a co-responder in Riley County. She graduated in graduated with her MSW in 2016, has worked outpatient mental health, substance use for years, working with the Riley County Police Department, crisis stabilization, and clinical licensed in social work. So we have our co-responder here, Brynn Haverkamp. Please welcome her to the panel. I'm now going to turn it over to our moderator, Tim Dewees, who is the director of Johnson County Mental Health, has a staff of over 350, provides services to over 10,000 residents within the county annually, has a Bachelor of Science in Psychology from Missouri State, Master of Social Work from the University of Kansas. Also served 10 years as an officer with the Army Reserve, National Guard, and is currently from Kansas, a representative on the National Task Force. We've talked about this national initiative of the court and the community's response to the issue of mental illness, and Tim serves on that National Task Force. And I will also tell you, before I turn the microphone over, that Tim and I work together closely on a variety of issues. I run our care and treatment, our AOT program. So in working with Tim in Johnson County Mental Health, I have had the privilege to get to know many of those 350 employees that he oversees. And I will tell you their commitment to investing in the lives of those with lived mental health experience, to investing in helping people with behavioral health need issues. I see this with so many of the employees of Johnson County Mental Health, and that is a reflection of the leadership that they have at the top. So with that, please welcome Tim Dewees.
So again, Tim Dewees with Johnson County Mental Health Center. I'm really happy to be here today. The amazing thing is that in 1995, and I know Dr. Balfour mentioned the 90s, So back in the 90s, in 1995, I joined Johnson County Mental Health Center to develop mobile crisis teams. And that was my first job, was to begin to start to look at this idea of mobile crisis teams. At the time, we didn't even call them mobile crisis teams. We called them crisis case management teams. And we changed the name because people said, why don't you have a mobile crisis team? And so we decided to change the name. Back then, our focus was really with police departments on community policing. That was the area of focus for them, crime-free neighborhoods. And so we really developed partnerships with all of the jurisdictions in Johnson County. And it wasn't very long after that officers started saying, you know, it's great, Tim, when you can come at midnight or 1 o'clock in the morning or 3 o'clock in the afternoon on Saturday to help us, but it takes, 30, 40 minutes for you to get there. It would be really cool if we were able to just have you with us, if we had boots on the ground. And so really it was early in the 20s, 2020, that we started to talk about this idea of co-responders. It took us a little while, but I think that it was that development and that work with the police departments that really shaped our agency and the commitment to work with both law enforcement as well as the court system to look at how we can better serve individuals with mental health issues in our community. And so when we look as we moved from the 90s into the early 2000s, we started developing the next thing after we started working and responding as well. While we'll look to see how we can develop co-responders, I think we need to maybe train all of us on CIT. And so in 2004, we created our CIT Council. In 2008, the county commissioners established our Criminal Justice Advisory Committee, which then set out on looking at how we could utilize the framework established by the sequential intercept mapping process. This is a SIM process. And so we had our first SIM process in 2010. From 2010 into the 20-teens, 14, 15, that's when we began to be able to introduce co-responders into the jurisdictions within our communities. So in 2011, we started with our first co-responder, and this year we will end the year with at least 21.5 FTEs worth of co-responders within multiple jurisdictions across our county. We are proud of the work that we've done, but there are still a lot of things that we need to accomplish along that SIM mapping process. So actually next week, we will be doing our third SIM mapping process through the county. And we'll be taking a look at where those gaps continue to lie. And so I think we'll continue to look at how we can better enhance the services that we provide at the jail, because the sheriff has in Johnson County, Sheriff Hayden invited us into the jail to provide the mental health services, and that helps be able to connect people. And we see some really good outcomes from that. It's also important for us to begin to look at some of the things that that Dr. Balfour talked about in regards to 988. Also something here in Kansas that's happening is CCBHCs, Certified Community Behavioral Health Centers. Those will all impact the services, and I think it provides an opportunity for us to revolutionize the way that we provide community mental health. So it's about the future. It's about developing those 988. But today, what we want to focus on, and you've heard a lot about how we can move the system in a positive direction. So today we're going to take a step back and start to look at that early intercepts, the early intercepts, so that we can deflect, divert, and keep folks from entering the criminal justice system from the very beginning. And so that's what our panel is here to talk about today. So what I'm going to do is ask each of them to take 5 minutes to introduce themselves and really provide their perspective from that early intervention, those early intercepts, and how their roles have helped in that early intercept. So I'll start actually with Lane, and I'll have him introduce himself, because really the first person at the scene is often law enforcement, and he trains the law enforcement. So I wanted to start with kind of the earliest onset that we have here. So Lane, I'll let you take the mic, introduce yourself, and share your thoughts. And again, 5 minutes.
Okay, I can do 5 minutes. I'll try to speak up. I've got a couple of my former students out there, and they know I have a very soothing voice that will put you to sleep and make you fall out of a chair. I've seen it happen, so I'll do my best not to do that today. As the judge said, and as Tim said, I'm Lane Mangles. I'm with the Kansas Law Enforcement Training Center. I've been there for about 2.5 years, and in my interview process, one of the things I had to do was lead a discussion on something that I thought was important for law enforcement, and obviously it was mental health. And so I came in there with my stack of mental health first aid manuals. I passed them out to the group, and I led this discussion. I was passionate about why cops need to do a better job of speaking with people who are in a mental health crisis, why we need to be more aware of what's going on with them, show some empathy, talk to them, and see if we can talk them into going to that service they need, see if we can convince them to go to the hospital instead of fight them into handcuffs and drag them to the hospital. So I was very passionate, and I was very animated about that. And then someone on the panel who ended up being one of my bosses looked at me and said, well, you do realize you're going to do basic training, right? You're not doing any of this in basic training, right? And that hit me in the face, but it also gave me some ideas of, yeah, I will be doing basic training. And when I got there, I started doing things like gangs and terrorism, which I knew very little about. And I started teaching things like financial crimes, which don't have much to do with mental health. But I realized that we can always be weaving this into everything we're teaching to the students. So if we're in a scenario now where they've de-escalated a person who's in some sort of crisis, and at the end of the scenario, we're doing a debrief, and they start to say, well, this person is schizophrenic, and they do, well, stop. We're not diagnosing, and we're going to use some person-first language. So if he does have schizophrenia, he's a person with schizophrenia. And if I can still plant those little seeds in our brand new officers in the state, hopefully, if they start to think when they get home to Morton County or Donovan County or whatever corner of the state they're from, I may not have the resources of a Sedgwick County or even what we had in Salina, which I think was pretty good. What can I do to help the folks in my community? How am I going to be a problem solver? How am I going to be a critical thinker? And how am I going to help overcome those problems instead of just complain, nothing's happening? We always have to drag this person to the hospital and then the long story of whatever bad happened. So that's what I try to do in our curriculum now. We've rewritten it, CPOST has approved it, and it's all about reinforcing and building on what we start in the first couple weeks, reinforcing all those good things, taking care of our communities, procedural justice, accountability. That's what's important to us, and that's what we're trying to convey to the new officers in the state. Was that 5 minutes, Tim?
That works.
All right.
Thank you.
you.
So next, as we move along that early intervention idea of the sim mapping, next I'll ask Brynn to introduce herself and share with us her perspective as a co-responder.
So like Tim said, my name is Brynn. I've been a co-responder with the Riley County Police Department for about 4 years now, going on 5, I think. But just recently, I also became the crisis director at Pawnee Mental Health. So I got promoted from the co-responder program. But this is definitely something that's still been very, very passionate for me. If you would have asked me as a social worker 5 years ago that my goal in life was to work with law enforcement, I would have laughed at you. They weren't exactly my friendliest bunch of people that I wanted to hang out with. No offense, guys. But that quickly changed. The co-responder program in Riley County started in about 2017. Like Dr. Balfour said, we started with the whole legislative side of things, or the community partnerships, where getting our county commissioners and everybody involved into wanting something like this. And we kind of did things a little backwards. We started with co-responders. We started with 1, and then we got 2 for a while, and we've kind of changed it up a little bit now. But the real hope for our co-responder program was to give the officers another avenue. A lot of times they would go out on scenes, they'd have a situation, and left with the same ideas of we either go to the hospital or we go to jail to fix that situation. And that just doesn't always sit well with everybody, and I agree with that. Starting with that co-responder program, as a co-responder, the biggest struggle for us is that language difference between an officer and a clinician. It is a completely different language. So being able to bridge that gap is the huge part of it. We spent countless hours doing ride-alongs with officers, going to their trainings with them. I've actually been to Lane's CIT training before with the other officers. And so it's really getting embedded in the police department to see how they work. And it was also for the officers to be able to understand like how the mental health side of things work. When we're just talking about like the basics of, you're right, you're not diagnosing things. I'm not necessarily diagnosing things out in the field either, but having to be able to work with a partnership of understanding what their limitations are and what my limitations are, and being able to come together on the more appropriate choice for that person. A lot of times we assist officers in determining if somebody has to be placed in like police protective custody based on their ability to be safe for themselves or safe around other people. So being able to be that partnership where they trust what I'm going to say, because having somebody as a stranger come in and tell an officer what they're supposed to do is also very challenging. And typically officers don't like to be told what to do. Especially by, a non-officer or somebody that has no credentials for that. So being able to really like be embedded with them is a huge barrier that we had to overcome. I know for a fact, most people in Riley County would tell you too. When we started this partnership with Pawnee Mental Health, not a lot of people liked Pawnee Mental Health. We were the community mental health center. Everybody had negative reviews, like all the bad things about it. And that was really something that we've had to work hard to fix in our community. Now I have, multiple officers, like we still, even if I'm not at the police department on a regular basis now, they're still calling me. They're still able to ask for help on what they need. And now being in charge of our crisis department, really being able to assist law enforcement in whatever I can do to help them. This 2019, we also opened a crisis stabilization unit, which is a 24/7 facility where officers are able to bring somebody to us. That was also a huge partnership with them, because I think when we started our co-responder program, we thought it was just going to fix everything, when in reality it doesn't. Because like Dr. Balfour said too, is like we can have all this response, that's great, but now what do we do with it? And so being able to have a place where we had an option besides the local ER, because they're not trained to deal with mental health, or it's not something that they're able to do in the ER on a regular basis. So being able to have a voluntary option, people are able to come and go. They're able to see a therapist very quickly. We don't have emergency access to medications though, so that would be something I'd like to change at some point to better assist people. And being that one-stop shop for law enforcement. As long as they meet our criteria for being able to come to us, they're able to drop somebody off, they go back on the street, they do their thing, and we try to handle it on our side. that as well was a huge thing for law enforcement. It still has its struggles because we don't have the level of care that, you know, we really could have. We don't have the security features. We don't have the safety features as far as being able to have somebody there that doesn't want to be there, or staff that are really trained to be able to help when somebody's on like the violent side of things. And we are just a voluntary center. So if it is that higher level of care, that involuntary situation, we do still have to utilize our ER facilities for that, and still have to utilize our law enforcement. But that's where like my focus at this point is making sure our law enforcement are trained very well. They spend countless hours with our co-responders. Since I'm not there all the time, Tiffany is one of our other co-responders that spends many hours like riding along with officers on a regular basis and doing a lot of that follow-up and outreach. Since we started our co-responder or our crisis stabilization unit, we also wanted to expand our co-responder program, which I thought was going to be a lot harder than it was. Since we had 24/7 therapists and we had all of our staff at their stabilization unit, we really wanted to have more support for our officers. So we started a pilot where dispatch could call our stabilization unit, and if one of our therapists was available, they could respond out to the scene with an officer. Surprisingly, out of my like 14 therapists, there was only like 2 that didn't want to do it. And so we did some additional training, got them regular stuff with the officers as well. And so then we changed our co-responder program to be a more like 24/7 response time. We still have Tiffany that's embedded in the police department because we still want that rapport building. We still want those officers being able to like learn from a clinician one-on-one. But then we also have multiple other therapists that are able to respond whenever Tiffany's not on shift, or if there's something that's happening outside of those normal hours of operation. I would love to expand this. Dr. Belfers gave me some very good ideas. So depending on legislation and all those other wonderful things, I am excited to see where things go. We are very new in this process. Like I said, 2017 was our first like co-responder program. CSU was 2019. So hopefully once our staffing shortages all get figured out in Kansas, we'll be able to keep doing more with that.
Thank you, Brynn. So next, before I go to Sheriff Easter, I want to do a little public service announcement, or at least a suggested course of action. So Judge Winnell mentioned that I was part of the National Judicial Task Force. We've also been a part, and I've been involved in something called the Stepping Up Initiative. And the reason that I want to mention the Stepping Up Initiative, it is a national initiative with the sole purpose of reducing the number of people that have mental illness in our jails. And when I say jails, I mean our county jails. So this is local. And so I just like, maybe by a show of hands, who's heard of the Stepping Up Initiative? Okay, so there's a few folks here. Here's the interesting point. There are only 9 counties in 13 now, sorry. There are 13, yes, I'm used to saying 9. There are 13 counties now out of the 103 that have sent 105. I need to get my numbers right. 105 counties in the state of Kansas. The key is that it starts with the community partnerships, and it starts with developing the partnerships that we've already heard about. But the other key is that you bring the county commissioners on board. In 2015, our Board of County Commissioners in Johnson County passed a resolution to essentially move forward with the Stepping Up Initiative. And from that, then we began to move pieces forward, and it provides you a roadmap. Piece of that roadmap, and Dr. Balfour talked about this, she likes data. I like data, or I like data as well. The interesting thing is that when you start to collect that data, you can start to tell stories. And as a social worker, we I can tell a really good story, but I haven't always been able or willing to back that up with the data. And so when you can start to collect data, and it can start anywhere. It can start by, like some of the data that I'm sure Sheriff Easter will talk about, is what the jail population looks like. You can start with simple pieces, but from that data, then you can start to tell the story, and you can start to know where to target the finite resources that we have. And I think that is the key. So with that in mind, Sheriff Easter, can you tell us, since 2017, you've had the mental health pod. So if you could just share with us a little bit about the history of the mental health pod since 2017 and what that looks like in serving individuals with mental health issues in your jail, and how you've worked to reduce that number.
Again, I'm Jeff Easter with the Sedgwick County Sheriff's Office. I appreciate the opportunity to come and speak to you today. Basically, in 2015, we started the process of looking at how we can better serve folks with mental health issues inside the jail. Traditionally in Wichita, we've been short on resources compared to the mental health population. So a lot of times officers just arrested them for minor violations and put them in jail. At that point, we have to start treating their medical and mental health issues. And so we worked with our contractor. We have a medical contractor that's 24-hour service with a doctor and nurses and those type of things, and built a program with them that we modeled after Santa Fe, New Mexico. And basically what that is, we have one whole pod of 50 inmates that we can hold in there. And by no way, shape, or form is that all the folks that have mental health issues that are sitting in the jail. It's 50 of the ones that have a hard time basically surviving in general population because they get picked on. Of course, as you know, they're the ones that are more susceptible to those type of issues. And so we spent it costs us about $750,000 a year. It's 2 CIT trained deputies that are always in that pod. And then the rest goes towards the mental health aspect of it, with the mental health nurse, technicians, psychiatrist, and all of those folks work together to give the same type of therapy that you would get on the outside, whether that's individual, group therapy, those type of things. You have to understand that we have some folks in there that have never had medical care or mental health care, and they're very sick individuals. And so it takes a while to get them to start taking medication again. So it's a step down. Once we get them to the point where they're actually interacting again, they go to another section within the pod where it's more of a group therapy and those type of things going on. We then, once they get to that point where we want to monitor them more with a population setting with other individuals that are suffering from mental health illnesses, we step them down to another section where there's more contact. It's been very successful for us. We also have a section in there for females. We don't have as many females, so they have one section where they're all housed together. What I will tell you though is we expected a rotation. Once we got them to that point, they'd go back to general population and we could rotate more people in. That's not what we're seeing. When we try to rotate them back into general population, they digress. Again, they're bullied, picked on, stuff is stolen from them, those type of things. And so basically once they get in there, they stay until they're released or until trial. So it's been very successful. It's a little bit of an expensive venture, but it's what we had to do. The other thing that we were able to do out of that is streamline the process of when they do get released from our custody. ComCare, which is our local mental health institution there, they come in about 2 or 3 weeks prior if we know they're going to be released in 2 or 3 weeks, but they start working files on them and start talking to them, and then also see if they can get them, if they're Medicare eligible, back on Medicare. Because as you know, when you come into the jail, your Medicare is done. And so all of that is a paying source that they have to, ComCare has to take and try to start that process again, which can take some time. When they are released, we don't just let them out the door. We take them straight over to ComCare. Luckily for us, ComCare is within a block. So we take them straight over there for that continuum of care. Because most of these folks will not continue to take their medication. If they're released outright, it's at least 6 weeks before they're going to have an appointment with ComCare. And at that point, they've digressed again. And then they're back in our custody or they're back in the hospitals, those type of things. One last thing that I'll mention is the co-responder. We started that in 2018. We only have one team, not 21, and would love to have 21. It's been very successful, but there's just not enough of them. The key to that success is the partnerships between EMS, ComCare, and law enforcement. The big issue there is EMS, to be real honest with you, because they can check them out medically right there on the scene, and we skip the ER room then at that point. Because that's why if we don't have, in general senses, when an officer or a deputy takes them into Via Christi, they have to go through a medical screening, which that is the part that can take several hours. And down there, there's no separation. So you might be there for your kid's broken arm with somebody that's in serious crisis right next to you. And so this skips that line and goes straight into the mental health hospital part of Via Christi. So those are things that really, from a law enforcement standpoint, are extremely successful. The other thing that I'll tell you about that is they are diverting a lot of people from the hospital, just this one group, and a lot of people from the jail. They're treating in place. And that's saving taxpayers millions of dollars by doing that. And so those are things that we hope that we can, we've been pushing to get more of that. I'm sure we'll talk a little bit more about workforce issues, and we all have them, and that's part of our problem. Thank you.
I think one of the things that Sheriff Easter mentioned was that cost savings. And I think that is an integral part about telling the story and backing it up with data. So if you create access, if you have access to care when people need it, you do it in a quality way, it contains cost across systems. The key for me at the Mental Health Center then has been to share with our local jurisdictions and the cities specifically about how that cost containment has resulted in their budgets. And so one of the things I talk about with the 21.5 co-responders is the fact that the county has not paid for any of those. The cities have seen the value and have paid for each co-responder that they have within their jurisdiction. So again, it's a matter of telling the story and backing up that story with that data. So moving to Dr. Balfour, I know that you just shared a lot of good information with us, but I was wondering if there was anything specific in regards to Intercept 0 to Intercept 1 from what you've heard thus far with Kansas. Are there any thoughts or suggestions about direction that we may go?
Yeah, I mean, it sounds like y'all are doing a lot, which is great. And a lot around the co-responder space, around having that, someone with you on certain calls that you've identified as mental health calls. And then you've got crisis centers, it sounds like. And how far is your county? Where is it?
Sedgwick County?
Yeah.
Straight down I-135.
Yeah, and I know we've worked
2
with,
hours away.
and then Douglas County is going to have a crisis center soon. So, and I'm sure there's other stuff in the works. And so it sounds like y'all are building the infrastructure. What I haven't heard much is about is where does 911 fit in all of this? Because I'm on the, back in Tucson, I'm on the committee that reviews bad outcomes when they happen. And so many of that stems from the communication that happens in the call center. And with all the focus on 988, I think that's an area to definitely start to dig into. And what I have learned in just the parts of it that I've been involved in is 988 or 911 is like a whole different world. But I think that that's a big piece also. But it sounds like what y'all are doing though is definitely like in line with what the best practices are. And so, every state's different. And, you know, like Arizona, we're all proud of we're all, all of the Arizona counties are stepping up counties. We only have 15. So, like the fact that y'all, we're pretty much the same number of counties have signed on as Arizona has, is great. So commend
I
all
will
that you're
also
doing.
just mention, it's also a pretty, a proud piece here in Kansas, in that we have a good plan for the implementation, the rollout of 988, and having call centers, 4 call centers, hopefully across the state. So that will be something that I think that will continue. One of the things that gets mentioned is that, it's different in each state, but it's also different in each community. And so while we have the same goals in mind, the way of achieving those goals may be a little bit different. So I'd like to ask Brynn about, is this doable in other places across Kansas?
Absolutely. I know as far as like Tim and Johnson County and all of that, they actually helped Riley County in figuring out like what we were going to do. Obviously, Johnson County is a little different than Riley County as far as size and everything like that. So we had to tweak things different from what they do and make it work for us. Since it is a smaller area, like we'll never be one of those areas that has 21 like co-responders, or even probably a specialized team of just like an officer and a co-responder or anything like that. We're just not big enough for that. However, we are able to tweak that for smaller areas. Pawnee Mental Health actually covers about 10 counties, which Riley County and Geary County are our biggest. And a lot of them are like the smaller counties like Jewel and Mitchell and some of those types of areas. And I'm going to tell you, my ultimate dream is that we have co-responders in all of our counties. And just depending on how that looks. With the more rural areas, we have a lot less access to care, just because like our closest acute facility is about an hour away. And so having a stabilization unit in Manhattan was a huge impact for us, because our closest thing was going to Stormont Vale or Salina Regional. And then a kid, if those places are full, you're looking at Kansas City or Wichita. And so for a 10-year-old kid that's going through a mental health crisis, having to go all the way to Wichita by secure transport, probably not by their parents, is a huge thing. Our crisis stabilization unit only takes adults. So being able to have an option for kids would be a huge thing. That's another tangent. But in those smaller communities, being able to tweak like how your co-responder program or how your outreach program works. And a lot of those more rural areas, I would think having like a co-responder that's more focused on like the outreach and the follow-up versus the acute like 911 calls would be a huge impact. Just your people that are calling 911 several times, or you've had a lot of interactions that week, just being able to get like a social worker in their home, even if it's with law enforcement, because in those smaller communities, law enforcement are your people. They're your neighbors, they're your people that know you by name and all of that. And so sometimes they're your in. So for that mental health person to be able to come in then with that person that they trust already, and being able to build that rapport and get them into the services that they need to hopefully continue those things, would be a huge impact. That's my biggest thing as far as that. I think no matter how big, how small, you could share co-responders. We're working on trying to do the Stepping Up initiative, where we have mental health in multiple jails, where we share that between different counties. So it's really like having to have those interdisciplinary, like inter-county collaborations to be able to make some of this stuff work in the smaller areas.
Perfect, thanks.
And Tim, I'm going to cut it for just a second
Yep.
to remind our Zoom listeners that in about 5 minutes, we're going to start taking questions from our audience for our panel members. So in about 5 minutes. So if you're watching via Zoom, if you want to go ahead and start to populate the chat with your questions. If you're in person, in just a couple of minutes, I'm going to come around and ask if you've got a question to raise your hand for our panel members, but we'll start that in about 5 minutes.
Perfect,
I want to
thanks.
say what you said earlier about how you've got, if people in your crisis center, want to sort of like be on call, that is so creative. And that's the kind of thing that I think you need for, more rural areas, like and everyone can't have like the big giant crisis center that's open 24/7 with a bajillion staff members. But it's similar to, I mean, we figured out in this country over however many years for medical emergencies, level 1 trauma centers, level 2, level 3, and those typically have, a regional pull, and there's a governance structure kind of around it. It's very similar to what I think we need to get to in crisis, where you're looking at what all the different communities are and where the resources are and how to make that work to get people the care that they need.
Thank you. So I have 2 questions left, and then we'll look to Judge Winnell to start the questioning and answering session. So my next question is actually about the importance of CIT training for officers in the community. And so I think it probably wouldn't be, it'd be the best to ask Lane, since he was the Kansas CIT Officer of the Year in 2017. The role of CIT in our communities, how important is that? And there's a lot of debate about 100% versus volunteer. What are your thoughts on that?
I was happy to hear Dr. Balfour say that it needs to be voluntary, because those voluntold officers, they might get something out of that 40 hours, but if they're determined, if they are that grizzly old, I've seen it, I've done it, I've taken that guy to jail, now I'm taking his grandkids to jail veteran, you're probably not going to change his outlook in 40 hours of training. So making it voluntary, I think, is huge. Now, I was voluntold to go to mental health first aid instructor training in 2014, and something went bang in my brain, and I suddenly realized I'd been doing my job wrong for the majority of my career. So some of those voluntold guys can get some good out of it, but I think that 30 to 50% is probably what agencies want to strive for. That way they've got a couple officers per shift, ideally, that can respond to those calls. But not everybody feels like they have to go to that training.
Super. Thank you, Lane. So the last question has to do with really the notion of community partnerships. And I think that we've heard that throughout the summit and again today. So Sheriff Easter, I know that with the Sheriff's Department, with ComCare, with Wesley Hospital, with the Substance Abuse Center there in Sedgwick County, along with other partners, how have you and what have you been able to accomplish with the Mental Health and Substance Abuse Coalition of Wichita, and how important are coalitions like that to making these things happen?
Yeah, so probably we've been coming up to the state legislature, a group of us had for about 7 years, talking about some of the issues, looking at different ways for funding for mental health, just because of everything that's been going on in the Wichita area, but also statewide. Western Kansas, of course, being based in Western Kansas, your ability to have those resources are very limited. And so it's not just a Wichita-centric problem or a Johnson County-centric problem, it's a Kansas problem. And so out of that came the notion that we're gonna have to start looking internally within our own county of how we can better address mental illness and substance abuse. From a gelling standpoint, about 33% of our inmates have a mental health issue. Over 70% have a substance abuse issue. So I'd be amiss if I didn't talk about substance abuse, because it is by far one of the things that is absolutely affecting mental health and law enforcement right now. So at that point, different partners from within the community. So we had Via Christi, ComCare, law enforcement, some Humankind, which is for homeless individuals, and about 2 or 3 other partners that came together and said, what are we going to do about this? And so we formed a coalition. It has business people on it, nonprofit people, government, those type of things. We're up to about 21 board members now. The key to it was, at least in the Wichita region, all the nonprofits were operating in silos. They had their own thing. Everybody competes for the same money and I understand that. They compete for the same money to keep their nonprofit going. But there were so many gaps in the system that was causing so many problems that we needed to look at as a whole to say, okay, no one's out after your money. The coalition isn't out after your money. We're trying to look at these gaps and how we bring people together. Now we have over 86 partners in it. And we've streamlined some of the services because someone that comes out with a mental health issue, unless you know that they have a housing issue, they don't get shipped over to Humankind or some of these other folks to look for housing. And those basic things weren't taking place all the time. And so we had an individual that had been booked 17 times, has some serious mental health issues. Finally, they figured out, well, he doesn't have a home to live in. Humankind took him in. We haven't heard from him in 3 years. And so those are the things that we have to work on as a community and have to tear down those silos and work together. And that's where that coalition is really starting to garner support from the business community and other communities on what it is that we can do. Now, it takes government to be involved. And so you have to have government because you're going to have funding. You have to have businesses involved. Hopefully they can give some private funding to build what our focus is to look at a social services hub in Wichita, similar to what they have in San Antonio, where you have your mental health, homelessness, and substance abuse items all in one area. So all of those services are together.
Thank you, Sheriff Easter. So now we'll look to you all. So who has questions for any of the panel members?
And if you do have a question, go ahead and raise your hand and I'll come to you, give you the microphone, let us know who you are and ask your question for the panel. And while I look for our first question from our audience, I will go ahead and share with you the first question that we received in our Zoom room. So this is for the panel. I work and reside in a small rural town. I would be interested in hearing from anyone with experience of implementing or how to initiate a crisis stabilization system, such as Dr. Balfour suggested, in a small rural community.
Anybody?
I don't know if
We're,
I. Go ahead.
Go.
Yeah, we're working actually in Montana, which has some rural parts for sure. And so it's, it's not a one size fits all. That's what I say. A lot of people want to come and see our crisis building and go, we need that. And there's the principles involved of getting people the care that they need and doing it in the least restrictive way. And like all these things, it's those principles need to be shaped to what exists in the community. And there's strengths in various communities. And so those things should be built upon. The place where we're working is the community mental health center is not really maybe able to do as much, but the FQHC there is like phenomenal. So we're working with the FQHC and building some mobile stuff on, with them. So that's one strategy, is like look where your strengths are and build upon those. Another strategy is like what you were saying with sort of economies of scale. You've got, and there's something similar like that out in Yuma, Arizona, where they have a living room and then there's staff who are staffing the living room. There's peer staff and then there's some clinician staff. And some of them are also the mobile team. So like when they're not doing one, then they're doing the other. So there's, out on someone asked me a question about what happens on the tribal nations out in Arizona. And that's another similar thing where that community actually having people come in from the outside and respond is mobile crisis. Like they don't want that. They want someone from their own community, but also, so they have staff that are there and they work, they take calls from home and then they're sort of on call, which is win-win because it's people from their own community, but the response times are better versus driving into the nation, which takes like forever. The stuff we're doing in Montana, like we probably can't do a 24/7 crisis center with that level of, the highly agitated and all of that, like right when they come off the street. And so we're working with the ER because they were looking at building like a psych pod And so have that be part of the pathway, but only for the portion that it's really needed, and then on to the crisis center. And so it's all about the flow and looking at how the patients go through it and looking at it from the perspective of what that patient needs versus, well, this is what I do. And so like, you know, like they just need to fit into my way of what I want to do. And, you know, getting everyone together to try to say, well, what makes sense and how can people collaborate?
And I am seeing some hands coming up, so I'll be getting around the room. But we have a question from first live question from an audience member.
My question is for Brynn. In the co-responder program that you have, we're very interested in starting our own in the 5th Judicial District. What are the titles or the credentials of your co-responders that are responding with law enforcement? And given that our resources might be different, are there any members of the behavioral health professional community that should be excluded from that?
So this is a good debate, actually. So with not just like our co-responder program, but even just like our crisis unit, we have about 15 to 20 therapists at any given time. I will tell you that like 90% of them are social workers. It's not to say that like there's anything specific as far as that. I know many other people that aren't social workers that are co-responders, but that's worked really well for us. And I think that's part of it is the social work profession was more on the mindset of case management, which that's a lot of what a co-responder is you're figuring out like how to connect people to the right thing. So it's not necessarily doing intensive like therapy in the field. It's more about how do we get the wraparound services that they need. So that's our experience is social work, but we also have one of my therapists has a PhD in psychology, and I have another one that's an MFT. I have some substance use licensed therapists too. So it's not exclusive to that. It's really more about the personality and the right fit for that person. Being able to like enmesh with like the officers, or being able to understand that sometimes we're gonna go stand on a bridge when it's -2 degrees outside, and being able to still have a conversation at that point. So that's really more of the concern than it is as far as the credentialing.
So before we go to our next live audience question, we have a question from a Zoom participant. Mr. Dewees, will 988 cover all the counties in Kansas, and how are the calls going to be routed through the counties? Will they go through dispatch, and how does it differ from 211?
So 988, the answer, the short answer is yes. There'll be availability. You'll be able to call 988 anywhere in Kansas and be connected with someone from the 988 system. The current system, as it stands right now, is you know, in Kansas specifically, is part of the suicide prevention Lifeline. And so there are 3 current call centers: Johnson County, Sedgwick County, and a place in Lawrence called Headquarters. And the idea currently is to then have a 4th. And so the key will be to be able to have those call centers. Johnson will take the Johnson County calls. Right now, our call center takes about 50,000 calls annually. And so we'll expect that to be the same or actually go up a little bit. We're already a National Suicide Prevention Hotline Center. The other is in Sedgwick County, and then Headquarters. We expect there to be a higher volume because 988 is a lot easier to remember than a 10-digit number. So I think that the key will be is for us to be able to have those 4 centers in place, and we don't have a whole lot of time. We're talking about July 16th goes live, to be able to have those 4 centers in place to be able to manage the call volume, because we want an effective answer rate. We don't want people waiting. And so right now in the Kansas legislature, there's a bill, and it's I think it's stalled a little bit, and that needs to move on. That needs to move forward so that it can ensure that exactly what you asked, that everyone in Kansas will be able to call 988, but this funding will ensure that there is a high response rate. No one will have to wait. someone will be able to talk to someone immediately. Within Johnson County, we're actually going to embed that 988 call center with our 911 call center. So it really doesn't matter where you call. If it's a mental health emergency, call 988. If it's another emergency for police or MedAct or fire, then you're going to call 911. But what we know is that in 911 call centers, there's already a number of people that call 911 for behavioral health. They'll just be able to pass that call off to our call center. So our plan is to take the next step and embed the two together.
All right, thank you. We have another question from a member of our live audience.
Good morning. Ken Lewis, Shawnee County Sheriff's Office, Operations, just a fancy name for patrols. So we're doing a lot of the frontline first responders. I'm involved with Topeka, Shawnee County, CIT, and KCETA. My question, I guess, for Lane would be, with regards to KLETC and training, you said when you came on board, you were a basic instructor. I know people move along. So in the training, it's 14 weeks now.
Yes, sir.
When I went through, it was less than that, so it's been a minute or two. So I apologize, but I think that's great. Is there adding whether it's the 40 hours or how much of the CIT training is in the basic course? I know there's continued ed, and a lot of us take advantage of that, so.
Yes, sir. It was 9 weeks when I went through, so it was shorter then too. And I actually came across some of my materials from when I went through basic training, and it hasn't changed a whole lot. We give them the basic recognition of signs and symptoms of a person that's in a mental health crisis. We tell them some good things and some not so good things to say when you're responding to that person. And then from there, we just, for the rest of the 14 weeks, we try to have them put that into practice. So if you want to call it a mini CIT, it's kind of a mini CIT that's broken up over 14 weeks. But I know Lawrence, when they do their own academy, they do a full 40-hour CIT as part of it. You may do that when you get your trainees back from us, I'm not sure. But we don't actually implement all of CIT or a full mental health first aid into the 14 weeks. We just try to take the best of the best and pepper that into that 14 weeks where we can make it fit. If I had my way, absolutely. But you know my boss, so you can call him.
There are some jurisdictions that do their own academies, and they have utilized the 8-hour, I think it's 8 hour, it may be more than that now, the 8-hour mental health first aid for law enforcement. So that specific program that's developed for law enforcement that's like mental health first aid for the general community, but it's specialized for law enforcement. And so some jurisdictions have said, well, we're going to make sure that everybody gets a base level training, and then we can look at the CIT as that optional 40 hours.
Yeah, that's what Tucson Police did that. So they put mental health first aid for law enforcement in the academy. And then they went back, and for people who had been out of the academy, like they had a way to get them all back over time and retrain, get them that training. And then a certain group of them became mental health first aid instructors, mostly from those specialty teams. And so then they've gone out and given mental health first aid training to like the Circle K clerks, because like half of our patients starts off disturbance at Circle K. Transit drivers, and so they went out actually in the public and were giving it, which was in terms of like community policing and building trust and stuff, has been a popular tool for that.
I appreciated Sheriff Easter's comments as it relates to mental health workforce. Are there any suggestions from the panel members on ideas to grow the mental health workforce within my judicial district or my county? Are there any ideas on growing that workforce?
So we have a workforce group underneath the mental health task force. And so what they've been looking at is several different options. I don't know, I'm just hearing it from them, that in the state of Kansas, the licenses that is required here is rather large compared to other states, which is a barrier. I just was on a phone call this morning where they were talking about that again. And so that there needs to be some discussions with the state about the licensure stuff that goes on within that community. Secondly, we're fighting a little bit of a battle in the service industry. So whether it's nursing, mental health, nurses at the hospitals, 911, EMS, cops, firemen, there was a lot of emphasis here several years ago on STEM, which is great. But a lot of those kids that was coming to these kind of services are now flooded in STEM. And that's put on, those are things that are done within the school boards, within the state of Kansas, really pushed STEM down to the school boards. We've got to figure out a way to come up with the service industry within the high schools that this is still out here and this is a path. And how do we do that? Do we do that through VOTEX? Do we do that through the high schools, getting more involved in those type of classrooms and talking about these type of professions? Because I can tell you ComCare is down 145 people. They are not functioning anywhere close to where they should be. The hospital staff at St. Joe is normally our mental health hospital there. St. Joe is diverting patients right now because they have 2 patients per 25 mental health, or 2 nurses for 25 mental health patients, and they can't sustain that. And so we're in a real quandary there right now, which I'm sure is like that across the state. And so the other thing is that looking at loan forgiveness, it amazes me, folks that get the bachelor's degree to be able to be a social service worker or social worker, and they have a lot of debt, but yet they're going to come in making $14 an hour. How are you going to sustain being in that profession plus your debt, let alone if you go get a master's? I have a daughter right now getting her master's at Friends in social work, and her debt is going to be rather high. And those folks start out at $20, $21 an hour. So there's got to be some type of system in place where we can look at like what doctors are getting on to go to Western Kansas and those type of places to become doctors, some type of loan forgiveness for these folks to draw them in at such low pay.
One thing that I would also like to just add to that is I do think that we as mental health centers, we do a lot of work with colleges and universities and training future therapists. But I do think we need to go back, and that's one of the things that we just started. There is a role, and it's called real world learning, that all school districts have to do, and they're at various levels. I'm finding all this out as I go across the school districts within Kansas, because I started talking with high school teachers, and they're typically around nursing or in a specific like CNA or welding, but there's this real world learning that happens at every high school. And so we have started to have that discussion about what does it mean to be a public servant? What does it mean to work in a public service industry, and start to provide opportunities for them to come shadow, experience, learn about the mental health center. And so I do think that Sheriff Easter, you're right on target. I think we have to go backwards, meaning that we have to move downstream, and it's develop that workforce from high school, because the shortage right now is not something that I think we can just hire our way out of. We need to build the workforce for the future.
So to all of our Zoom participants, we've received numerous questions. Thank you for those. We do have time for one remaining question. We have an audience member with a question. It'll be our final question for this panel. So if you're on Zoom, thank you for submitting the questions. We're going to end with one in-person question, and then I'll turn it over to Tim for final comments before we conclude this panel.
Well, and it was kind of timely because that's where I was heading, and I wondered if Dr. Balfour, what you have seen with some of the other states that you've worked with on, as Sheriff Easter, he stole my thunder, but he kind of does that because he's pretty good, with the criteria for licensing and certification of all the individuals that we need to help us in this area of mental health. I mean, we have a health crisis, period, in workforce, but it's really starting to hit home with the mental health side.
Yeah, and everyone, I think, is feeling this crunch. Arizona is fortunate in that we've had a robust peer workforce for a long time, partially because it was part of the settlement of the lawsuit that led to us getting Medicaid, like from the 80s. So having peers can do a lot of this work, and not just as a replacement for like people with quote higher degrees that you can't get, because they really add a lot. So and that is something where, you know, there's all this untapped potential workforce, because anyone who's, you know, in services now is a potential, or has been as a potential peer, and can use that life experience as their credential. That's how I kind of, you know, philosophically, it's like that's their credential. But then the state, and I'm not sure if I think your state does have a certification program for peers, and so that's like one, you know, hugely potential resource that can be tapped. Having creative ways to do supervision, so having your bachelor's level people who are under the supervision of someone with a master's. Every state is so different, especially in the social services credentialing. I think some things can be done to make it where, I mean, I have friends who have a license, like an LPC, like the degree in another state, but then they move to one other state and they want them to redo all their hours. And so then they work, you know, like doing something completely outside of the behavioral health workforce. I mean, that's something that I think, I know some states are looking at trying to streamline that. The loan forgiveness stuff, a lot of the programs, the ones for physicians and licensed people, don't include crisis. I've been trying to get our centers certified for that forever, and they want you in a clinic, or they want you at 40 hours a week, and if you work shift week, it's like 32 one week and 48 another. They're like, nope, that's not 40 hours a week. So some of that's at the federal level. Some of that, though, there's state loan repayment programs that get their money from the feds, that I don't know how loose you know, how much leeway they have to regulate things differently at the state. Those two bills that I put up there, I think it's the second one, has a bunch of stuff in there about allowing crisis sites to be loan repayment. So there's just tons and tons of stuff. I do think in terms of marketing this work as something that to be attractive, is a lot of people are drawn to work where that they're interested in, like social justice, and like what can be more social justice-y than, you know, working with law enforcement to make our communities safer and also get people the help they need, rather than, you know, end up in the justice system where they don't belong. So I think there's a lot can be done too to kind of talk up this field as the exciting, you know, meaningful, impactful work that it is.
So as we wrap up, I just want to thank Lane, Brynn, Sheriff Easter, Dr. Balfour. Thank you for being a part of this panel, and let's give them a round of applause. Thank you. And since Judge Winnell said that I could make a closing comment, I'm going to take the opportunity. The single most important piece of legislation, mental health legislation, was passed last year. It was the CCBHC law, and I would say that it outrivals the Mental Health Recovery Act of 1990. So it has been several decades since a piece of legislation has been passed that can transform the mental health landscape within the state of Kansas. And what the CCBHC model entails is it requires 9 services, but more importantly, it changes the way that mental health centers are reimbursed for care. It moves us out of a fee-for-service model into what they call a prospective payment model. And so that you are paid based upon the cost of providing that service. And so I expect that as we continue to move forward within the state, and the first 6 CCBHCs will be in place hopefully by May, followed quickly by another 2, as I look at Commissioner Brown, in July, and that will give us a total of 8 CCBHCs in 2022. That will create an influx of funding across Kansas for mental health. So when we talk about some of the things that we talked about today, how can we do more CIT? How can we look at how we can provide some of these services in rural areas? How can we work together, and where is the funding going to come from? There's an opportunity. I shared with the Board of County Commissioners a couple of weeks ago as I was talking with them about CCBHCs. For me, it is exciting time. It's an exciting time to be a mental health director in the state of Kansas, because the legislature, bipartisan support, passed this bill, this piece of legislation that will transform the mental health system in Kansas and provide us an opportunity to do all of the things that we are talking about today. That's why I think it was so important for Judge Winnell and the group that went to South Dakota and brought this summit back, because next is going to be the task of coming up with what needs to happen in each of your individual communities, so that you can create the Riley County model, or the Shawnee County model, or the Sedgwick County model, or the Johnson County model. Whatever model you all develop within your jurisdictions, there will be opportunities. As long as you involve the community mental health system, there will be opportunities to fund these initiatives. And so with that, I'll turn it back over to Judge Winnell.
Thank you to our panel members.